Good evening, everyone. Today we are here for the ICS webinar series. I sincerely thank Dr. Rakesh Chawla, President ICS, and Dr. Amita Nene, Madam Secretary ICS, for giving us this opportunity in this ICR webinar series. Today's panel discussion is going to be on steroids in pulmonary medicine, the indications decoded. And this is a very simple topic if you see it, but a very powerful topic for every pulmonologist out there. And steroids have been the bone of contention in every discussion by every influencer in India. So let's speak about steroids in pulmonary medicine. For this, I would like to introduce our speaker for tonight. She needs no introduction. Dr. Thilagawathy, madam. Can we have her CV, please? So, ma'am is obviously a pulmonologist. She's an HOD and senior consultant in respiratory medicine and sleep medicine in Vijaya Group of Hospitals in Chennai. She is a treasurer and co-founder of Association of Women in Pulmonology, associate editor for book Pulmonary Disorders in Women, co-editor and author Handbook for Respiratory Therapists, and awarded the Inspirer in Pulmonary Medicine Award in 2023 by ICS. So, ma'am, I hand over the forum to you for your talk on pulmonologist prescription mastering the art of steroid deployment.
Good evening, everybody. Thank you for that wonderful introduction, Doctor. Let me share my slides first. So, are you able to?
Yes, ma'am, it is visible.
Am I audible also?
Yes.
Yes, okay. So, good evening to everybody. Thank you for logging in. I think this is such a wonderful topic. I thank Dr. Amita Nene, the ICS, and the entire panelists for being here today. And I'm looking forward to a great discussion because such an interesting topic. So I think steroids in pulmonary medicine, I think steroids are the most powerful drugs and most used drugs by all pulmonologists. And I would also say most misused drug also. So the art of prescribing steroids is not by reading only the indication, but it's also we should know when not to use the steroids, which is very important, and we should be aware of the side effects and other effects what steroids bring. But they are game changers and they are the go-to life-saving drugs in certain situations where you should not delay introducing steroids, giving steroids to these patients. So in the next 20 minutes, I'm going to walk you through some of the indications. So we will take traffic light. So what are the green signals where we will say, yes, this patient needs steroids? What are the yellow, maybe you're in between that and when you should choose steroids, and mainly contraindication diseases where we should not use steroids. In this whole scenario, we should be very, very aware that steroids are the most powerful drugs and need to be used in certain diseases. You should not be denied where the consequences can be grave. And the consequences can be even grave if you misuse them in some diseases. So the first slides are not moving. Not able to move the slides.
Click on the slide, ma'am. Click on the slide and then move.
Yeah. Okay. So
click. Yes.
Okay. Sure. So, so the next one, so what we are going to do today in the next 20 minutes, obviously I can't cover all the diseases of the entire pulmonology. I'm going to look at only the indications where it is definitely needed, where it is maybe, and where it is not at all needed. And I'm not going to look at what type of steroids, what is the dose you're going to give, or what are the contraindication, what are the side effects, all those things we will leave it for the panel discussion. I'm going to give you a brief bird's eye view about the indications of where in pulmonology we are going to use steroids. So the first one, so by the end of this lecture, you will be damn sure where you're going to use steroids. Tomorrow in your practice, you will look at the patient in a different way before starting steroids, not by the name of the diseases, but is this the driver of what the disease is, an inflammatory process, and is this patient going to benefit by giving steroids? That's the meaningful talk for today, meaningful message for today. Okay, the first and foremost, let's go through some common diseases. So the asthma is the one thing, asthma is what we are all aware. This is where steroids work like wonders. And no, with no doubt, I think across the platform, everybody knows that ICS is no longer an option in asthma, but it is the foundation. And every patient with asthma should receive an ICS containing regime. I think there is no doubt or confusion in this. So inhaled corticosteroids are the go-to choice for asthmatics because they are the core anti-inflammatory treatment. And then if you, so let me point. Okay, so this is the core anti-inflammatory treatment. I think no doubt about it. So it is across all steps in your asthma care. For low dose ICS, be it a controller, be it a reliever, marked in step 3, everywhere it is ICS formoterol. So controller, reliever, and all those things. So before going to oral corticosteroids, the most important step in asthma is you need to escalate inhaled corticosteroids, reach from low dose to the prescribed dose or the needed dose for the patient, high dose, and then only you can think about oral corticosteroids. So what about oral corticosteroids in asthmatics? It is only for moderate to severe asthma exacerbations, and it is only for a short course, 1 milligram per kg, and do not extend it. It doesn't need any tapering if you're using it for less than 14 days. You give only IV prednisolone, methyl prednisolone, not oral, in severe situations and in ICU. And there is for chronic steroid therapy, like chronic oral corticosteroids in asthmatics, if you come to that stage, then I think there is a great game-changing paradigm shift in the last 2 or 3 years, where you should really come to a point, you should test your diagnosis. So to have chronic oral corticosteroids in asthmatic, the patient should be a severe asthmatic or an uncontrolled asthmatic. But to say that this patient is severe or uncontrolled, first of all, the patient needs to have asthma. So here at this point, wait, take a step back, and then go through your diagnosis, go through the phenotypes, go through the mimics of asthma, and then only, and is this patient a candidate for biologics? Steroid sparing issues also we should keep in mind, and then only you can start oral corticosteroids, which is not only for the last resort cases worsening despite all your measures. Your phenoendotype the patient and asthmatic, and patient is having recurrent ED visits, severe exacerbations. Do not institute oral corticosteroids before going through all these steps. So the pitfalls here is you need to have there is no role for SABA only treatment. We know more than 2 steroid bursts in a year, that the cumulative steroid burden in asthmatic, you should be aware of that. And there is no role for long-term prednisolone, and ignoring the inhaler technique is a big no before giving oral corticosteroids. In COPDs, it's different. This is a different player. Steroids are only a guest here. There is never permanent. In COPD, you should be very, very careful. As far as inhaled corticosteroids are concerned, the goal is very clear. There are only 3 situations. One is you add ICS to LAMA and LABA only if the blood eosinophil count is more than 300 and the patient is a frequent exacerbator. If the blood eosinophil is 100 to 300 and more than 2 exacerbations, then he is also a candidate for ICS. And if there is an asthma COPD overlap, then that is also he's also a candidate for adding inhaled corticosteroids. Be aware that before adding inhaled corticosteroids or withdrawing, you should be aware of recurrent pneumonia, previous mycobacterial infections, and recurrent infective exacerbations. And also you should be aware that these patients, if they have frequent respiratory tract infections, they are also not the candidate for inhaled corticosteroids. So in exacerbations of COPD, I think this is one platform where asthma and COPD agree. Most of the times they don't agree. In exacerbations, short course of steroids are indicated in severe asthmatic exacerbation, as well as in moderate to severe exacerbations in COPD. And it's only should be for 5 days and not more than that. That's what the goal says. So summarizing asthma and COPD, asthma use ICS early, broadly, proactively. In COPD, use it as targeted. As I mentioned, only 3 scenarios where you can use. And be aware of the infection risk. Don't just keep on giving inhaled corticosteroids in a COPD patient. Exacerbations are only short courses. In a overlap syndrome, treat like asthma. Small airway disease, there is no final consensus, but we should be aware of small airway disease because this is such an early, finding out obstructive airway disease early. So we should be able to identify these patients also and then maybe target inhaled corticosteroids which reach the small airways. So eosinophilic lung disease, I think this is whenever there is eosinophil, it is like if you give steroids, it is like snow under the sun. It melts like snow under the sun. These are the diseases where pulmonologists are magicians here. If you institute steroids in these patients like magic, the patient will improve. Be aware of these conditions. So acute eosinophilic pneumonia is an emergency situation. Make the diagnosis confidently, and then if you give methylprednisolone, there is complete resolution. But chronic eosinophilic pneumonia, that also resolves very fast. And then you can taper the steroid over 6 to 12 months, but be aware that these patients have frequently relapse, and then they might need steroids regularly. The Loeffler syndrome, it is not regular steroids, it's only a transient pass. And ABPA, all of us are aware, this is one of the phenotype of asthmatics and asthmatic airway diseases, where steroids play a main role, can be a game changer here, with or without antifungals. So moving on to the next big player, interstitial lung disease. I think I'm going to spend a little more time on this. So in interstitial lung disease, there is no blanket treatment of steroids. Here you should be very clear what phenotype you're dealing with. So immediately, if you're dealing with an inflammatory phenotype of ILD, then steroids work like magic. If you're dealing with the fibrosis end with a UIP pattern, traction bronchiectasis, be mindful of that. If you have IPF and things like that, that steroids are not indicated. So you first need to identify the pattern on the CT scan to determine whether steroids will work in these patients. So for that, it should be a connective tissue ILD. You can have a pattern like organizing pneumonia, ground glass opacity, consolidation patterns, nodules, all those things, cellular NSIP, all this will work like magic if you give steroids. But if you are in the other end of the spectrum where there is IPF, here you should be very mindful that steroids can be harmful because it is already scarred and the damage has been done. So again and again, I think the postgraduates should learn to identify what are the inflammatory markers clinically, what are the inflammatory markers biochemically from the blood and other things, and what are the inflammatory changes in the CT scan. So these are, you put all these three together, then you will definitely be sure whether this patient, if you institute steroid in this ILD patient, the patient will improve or not. So you should identify the inflammatory phenotype. So what are the interstitial lung disease which are steroid responsive? As I told you, cryptogenic organizing pneumonia is one, cellular NSIP, acute eosinophilic pneumonia, hypersensitive pneumonitis, which is the cellular pattern, not the fibrotic pattern. And in selected CTD-ILD, the 2026 EULAR criteria, they are very clear. It is not steroids across the blanket treatment for the entire CTD-ILD. There are some inflammatory phenotypes which you need to identify, which I will talk to you in a little bit, and in acute exacerbation of interstitial pneumonias. These are the places where steroids are responsive. Where it is harmful and where it is you should be cautious is when it is something like IPF and end-stage fibrosis like UIP pattern and things like that. And if you have acute exacerbation of IPF also, here it is not a go-to, it's a conditional recommendation and weak evidence. You can have short course of steroids. And you should avoid steroids in IPF-like issues. In PPFP, there is clearly no evidence. So what happens to the next ILD part? That is the autoimmune disease with vasculitis-related lung disease. That is the autoimmune pulmonary disease. Here, high doses of steroids are warranted. It can open the door, but it cannot be a permanent player. We need to look at steroid-sparing agents. And nowadays, this group of drugs in the new EULAR criteria, there is a lot of, rituximab and other immunosuppressants which play a major role. Of course, for the induction in all these vasculitis, you need to give a steroid, but after that, you should look at steroid sparing agent, or you should upfront be a combination of steroid plus rituximab or cyclophosphamide and things like that, depending on the disease, what you're dealing with. You're dealing with GPA, MPA, it is going to be steroid, prednisolone plus either rituximab or cyclophosphamide, depending on these two have their own positive points in the reproductive age group. You cannot give cyclophosphamide, you can go with rituximab. So there are some plus and minus here. And in pulmonary alveolar hemorrhage, it is definitely sometimes pulse dose steroids also, and plasmapheresis and other supportive care. Myositis ILD is another one inflammatory phenotype. Even if you see some fibrotic pattern like UIP or traction bronchiectasis, this is one phenotype where there is a rapidly progressing ILD. So if you diagnose myositis ILD, irrespective of the pattern, you're supposed to give steroids. And the other one is EGPA. EGPA in non-severe, you can give steroids for mepolizumab. In severe, it is either steroids and rituximab plus cyclophosphamide. So, and all acute lupus nephritis, pneumonitis warrants pulse dose of steroids. So, and then in rheumatoid arthritis ILD, another very important. So, if you have even if you have a pattern which is a UIP and then you diagnose rheumatoid arthritis, this rheumatoid arthritis ILD phenotype behaves like IPF. Remember that. So, in this rheumatoid arthritis ILD, you should be cautious of using steroids. The other immunosuppressants will be the forerunner than the steroids. But in myositis ILD, it is a even if you diagnose fibrotic ILD, you need to give steroids. We'll look into that a little bit. So in hypersensitive pneumonitis, definitely steroids are a go-to drug. Here also they are very, very important drugs. But you should remember the first and foremost across all hypersensitive pneumonitis is remove the antigen first, then treat the phenotype. Now look for whether it is a non-fibrotic inflammatory phenotype where steroids will play a major role. If it is a fibrotic phenotype also, in that, suppose you have a non-fibrotic, then it is go-to, it's a cornerstone of treatment. But most important, don't forget to remove the antigen where keeping the exposure there and then giving steroids is like, hugging the allergen and giving antihistamines. So it works like that. So it doesn't work like that. You have to remove the antigen. So in a fibrotic HP, what are the places where you will give steroids? So if you have a ground glass opacity and if you feel there is new onset inflammatory changes, if there are mixed inflammatory fibrotic phenotype, and if your BAL lymphocytosis is clearly more than 30%, these are places, even if it is fibrotic HP, you should give steroids in these places. What happens if it is progressive fibrotic HP? Here, the guidelines are very clear. Steroids have limited evidence. And here, there is a big role for antifibrotic therapy. And you should also look at steroid sparing therapy. So what are the practical pearls as far as HP is concerned? So antigen avoidance is the hypersensitive pneumonitis across the board in all types. You have to practice antigen avoidance is the treatment. Steroids are only a bridge. They can quieten the inflammation, but only antigen removal changes the disease trajectory. Remember, it is like if you give only steroids to a HP patient without removing them, it's like applying Band-Aid to the lung, and still the fibrosis will continue. So the latest clinical position is not always give steroids or never give steroids in HP. It is treat the inflammatory phenotype with steroids, minimize the steroid duration, transition early when relapse or toxicity emerges, and even in progressive fibrotic HP, you have to practice exposure control, which is very, very important. So these are the practical pearls for ILD as a whole and steroids. Before prescribing, define the pattern as I told you. And then there is no blanket treatment across all CTD ILDs. Remember that. Do not leave patients on long-term steroids, even if you have a connective tissue component, without a steroid sparing plan, which is like, tremendous boom on all the combined immunosuppressions and for various CTD ILDs, which I'm not going to talk to you today. So we should be aware of all that. And have a check on systemic sclerosis ILD, which is the key exception among CTD ILDs because it can produce, if you introduce glucocorticoids here, it can produce scleroderma renal crisis. Be aware of that. And there are situations where in scleroderma also, you can give low dose of steroids if you find an inflammatory phenotype. That is a separate discussion. So the key question you should ask in ILD is this ILD driven by inflammation? Then if you find the right phenotype, don't hesitate to give steroids. So now I will tell you some tips from all the guidelines together. When you should use steroids, this is the question which nobody will address. So I am telling you here, this is like, when you should use steroids when you find, even if it is fibrotic ILD, what are the practical pearls? First, as I told you, clinical, biochemical in the sense you can do CRP, ferritin, D-dimer, all the inflammatory markers you can do. Clinically, patient is worsening and radiologically you see some new findings and the clinician is convinced that this is definitely there is an inflammatory process. please don't forget to try steroids in this. So go with the CT, and then if you have a lung function which is also from deteriorating, and then you think there is a new onset inflammation, you can try steroids. In BAL, lymphocytosis more than 30%, definite strong support for the use of steroids, even if it is fibrotic ILD. So in IPF, it will be less than 5%. So you can boldly give steroids here. If BAL has 20 to 30% and you have some supportive evidence like CT scan and other things, still you can try steroids in them. Another thing is steroid treatment in fibrotic should be considered if the underlying associated disease is known to be inflammatory. So as I told you, if you have myositis ILD, it is definitely warranted. If you have cryptogenic organizing pneumonia pattern, definitely you can give steroids. And then if you have scleroderma pattern, definitely you can't give. So if you have RA-ILD, you cannot give. Within the inflammatory pattern, you should pick up that inflammatory phenotype and then subject them to steroids. In the CT scan, this is a clue. This is a practical point. If you see UIP pattern, you're seeing honeycombing, you're seeing traction bronchiectasis, but then you are seeing consolidation and ground glass opacities in areas without traction bronchiectasis, which indicates pulmonary inflammation. So if you see this consolidation and GGOs in areas apart, areas away from your traction bronchiectasis and honeycombing, then definitely that is pulmonary inflammation. That's a clue that this patient needs steroids or he will benefit from steroids. But there are currently no systemic markers that, according to guidelines, there are no systemic markers. But I would say you can combine some amount of biochemical markers, CT markers, clinical parameters, and then decide. So if steroid treatment is initiated in fibrotic ILD, be aware that you should be following up these patients. So especially in the phenotype, an acute exacerbation of ILD also, you can try steroids. So in the MDA5 and other things, you should have a follow-up of these patients and then always be aware of side effects and also of the other, immunosuppressive treatments. So the sarcoidosis, this is another one, the great mimicker which loves steroids. So in sarcoidosis, in an asymptomatic patient, there is no role for treatment. Even if you identify n number of findings and lymphadenopathy, and then you demonstrate biopsy, non-cacheating lymphoma, everything, non-cacheating necrosis, everything, but still if the patient is asymptomatic, hold back your treatment, observe him, and then watch. So there are places where you should definitely treat. So it is organ specific. If you have cardiac sarcoidosis, neurosarcoidosis, ocular sarcoidosis, and in pulmonary stage 2 and 3, and hypercalcemia, please treat these patients with steroids plus or minus your other immunosuppressions depending on the phenotype. So if there is a stage 1 and asymptomatic, and usually it is self-limiting, please don't use treatment there. So practical pearls for sarcoidosis: in practice, the steroid plan should be driven by organ risk, symptoms, and how quickly control is needed. Do not treat asymptomatic, and you should be aware of the steroid sparing agent. In the latest trend, anti-TNF revolution is in a big way. So infliximab is almost like a steroid sparing agent. So you can use it in sarcoidosis. Coming to severe infections like severe community-acquired pneumonia, I think this Cape Cod trial, all of you are well aware of this trial. So this was the game changer where it said that in severe community-acquired pneumonia patients, you can use steroids. Before that, there was, nobody even thought of using steroids for a community-acquired pneumonia. So this is the paper which was a game changer. Here, see, imagine this is not for across the board for all pneumonia. Please remember that. It is only for severe CAP patients who are in the ICU needing mechanical ventilation or vasopressors and who are having a very poor pneumonia severity index, curb, hypoxia and all those things. And what they did was hydrocortisone. So be aware that in this Cape Cod trial, they said that you should be screening for IPA and kappa, which is COVID-associated pulmonary aspergillosis, influenza-associated. All this should be kept in mind when you are instituting these patients on steroids. So there is a controversy in so many guidelines between critical care guidelines and our IDSA and ATS, ERS, as well as our own Indian guidelines on which steroid to use in pneumonia, where to use, which patients to use. So this is a big controversial topic. But please remember, severe CAP requiring ICU treatment, mechanical ventilation, NIV, and things like that, definitely there is a role of steroid. So if there is a sepsis, so if you see the septic shock and most of the sepsis guidelines, they will go with hydrocortisone because they want the mineralocorticoid effect. This is patients on vasopressors and then you're giving steroids. So this is hydrocortisone. So for us, it's so in ARDS also. So between hydrocortisone, dexamethasone, and methylprednisolone, guidelines are very clear. There is no clear cut evidence that this is the steroid you should use. Depending on the patient, whether your patient is septic, infective, then you will definitely not use a dexamethasone, which is long acting. So you can use glucocorticoids. Depending on the desaturation, you want a good glucocorticoid or an anti-inflammatory action, you will choose methylprednisolone. So depending on the situation and the phenotype, please refer to the guidelines and use it accordingly. There is no clear indication for one over the other. So this is another ARDS trial, DEXA ARDS trial. I think everybody is aware of this. This was another game changer where this is what this is a COVID lesson we have learned, a steroid lesson, which was a game changer during COVID. So this is that, that recovery trial where they use DEXA, and then because you need to identify in an ARDS patient whether this patient is an inflammatory phenotype. Again and again, I'm stressing. So steroids are ARDS, you can give steroids, but when, how, which patient, that's very important. So the patient should be an inflammatory phenotype, and it should be given early, less than 14 days, not later in the stage where the fibrosis has set in, and no preferred steroid molecule. There are studies with all the molecules, whichever you're comfortable with, I think you can use it. So in tuberculosis, this is the last infective this thing. I think no talk will end without tuberculosis. Here also, it is not across the board. It is a game changer in certain situations, but it should be used with caution. I think one message what I want to tell is, if a patient has tuberculosis and you want to give steroids, it cannot be without anti-tuberculous treatment. So the first preference should be anti-tuberculous treatment, and then look at the phenotype and then give the steroids. So approved indication are for TB meningitis, pericarditis, adrenal TB with Addison's disease, and severe iris. So you should be very, very cautious in using in other conditions. It's not for all tuberculous effusion. It's for endobronchial TB. Here also, this is only for a particular phenotype where there is obstruction and severe stridor and things like that, or is it the airway is going to be at a compromise. This is the individual call on individual patients. In hypoxic pulmonary tuberculosis and biliary TB, this is only if the patient in respiratory failure, you should be thinking about steroids. So the golden rule is ATT started before or simultaneously. It is never steroids alone for TB, never ever. If you give TB steroids without ATT, it's like lighting a fire and pouring petrol over it. Always cover first. So steroids are the heroes and villains of pulmonary medicine. This is a summary slide. It's a green light for all this. I know whenever there is eosinophils, asthma, vasculitis, particular phenotypes in connective tissue ILD, as we discussed, hypersensitive pneumonitis, the inflammatory or the cellular type, sarcoidosis with a specific organ thread, severe CAP, moderate severe ARDS, septic shock, and adrenal insufficiency. These are the green light. This is the important thing. You have to give steroids in this group. Where you have to be cautious is when you have a fibrotic ILD, when you have severe viral pneumonia, endobronchial TB with airway obstruction, miliary TB with hypoxia and sarcoidosis. This is an individualized call on a case-by-case basis. And the red light is when you have a UIP pattern, IPF, and routine viral pneumonias without a steroid responsive phenotype, non-severe community-acquired pneumonia, routine pleural effusions, all this pulmonary tuberculosis, all these phenotypes, you should never give steroids. So steroids are the most powerful drug in pulmonology, can be a cure, a bridge, or a mistake, depending on who receives it. So your question should be at the end of the day, does this disease have an inflammatory process that steroids can meaningfully modify? This is one, I think, from this whole talk, you should be asking this question to each patient in front of you. If the answer is yes, steroids will help. If the answer is no, steroids may harm. If you are unsure, then phenotype the disease before prescribing. So the art of prescribing steroids is knowing when not to use the steroid. So use the judgment, evidence, experience, and compassion. Balance is the key. In today's practice, I think if you use all this, if you keep in mind all this, I think you will prescribe steroids judiciously and make it a life game changer or a life-saving drug in your practice. Thank you very much for your patient listening.
Thank you, ma'am. It was an excellent talk. To cover such a vast subject in 20 minutes, hats off to you, ma'am. I mean, it was a full packed slides, learning when to give steroid, when not to give, what to do. You can cause more harm than benefit. I think we also learned a lot, even though we have been practicing and using steroids for a long time. And now to take this discussion further, we have a nice panel discussion for you where we'll be discussing the various aspects of where the steroids can be placed. I've been told that there are already more than almost 1900, I think 1800 something logins. Let me be sure, 1876 logins, and there are more than 150 questions. I hope we get time to answer those all. I have prepared some questions, and probably those should answer all the questions that I can see in the chat box that have been put. Can I get the CV slides of all the panelists? So for this power pack discussion, we have a very eminent panel with us. Starting off, yeah, can you make it full screen, please? So first is Dr. Dinesh. He is pulmonary critical care specialist, head of Department of Interventional Pulmonology and Critical Care Medicine at St. Philomena's Hospital. He's a chairman for PSPB healthcare areas of for healthcare, and areas of interest are reactive airway disease, interventional pulmonology, lung cancer, and ILD. Welcome, Dr. Dinesh. Next, we have with us Dr. Lovleen Sharma. She is a DM Pulmonary Critical Care Medicine Specialist. She is consultant pulmonologist at Kailash Deepak Hospital, Delhi, and she has won multiple awards, of which NAPCON 2020 Young Scientist Award was one of them. And she is member of Indian Sleep Disorders Association and Indian Chest Society. Welcome, Dr. Lovleen. Next. We have Dr. Umar Saifee. He is a consultant pulmonologist practicing at Sri Ram Murthy Smarak Institute of Medical Sciences at Bareilly. His areas of interest are bronchiectasis, ABPA, interventional pulmonology, and ILD, and he has multiple publications and achievements. Welcome, Dr. Umar. And last but not the least, Dr. Sujay. Dr. Sujay is a DM Pulmonary Critical Care Medicine and also has an MRCP. He's a consultant pulmonologist at Sparsh Hospital, RR Nagar. His areas of interest are post-tubercular lung disease, interventional pulmonology, and ILD. And he has multiple research publication, book chapters, and he's semi-certified fellowship in ECMO and certified in palliative pulmonology. Welcome, Dr. Sujay.
Yeah, I think I will take the pleasure of introducing our moderator. Can I have the slide, please? Yeah. So this is Dr. Mehul S. Thakkar from Mumbai. I think young pulmonologist, enthusiastic, who's going to take us through a wonderful panel discussion now. He's got over 16 years of experience, and he's the director of Medansh Multi-Speciality Hospital in Mumbai. He's a DNB guide in Jupiter Hospital, Thane. He's a honorable treasurer for Indian Association for Bronchology and organizing secretary for TESCON Mumbai 2025. He's got multiple national and international publications. Doctor, thank you so much for being here. Over to you. I think you can take the proceedings from here.
Yeah, thank you. Thank you. Can we just stop this thing? Okay, so let's start our panel discussion with the first question. First question goes to Dr. Dinesh. So despite the newer therapies that have come, ma'am spoke about a lot of immunosuppressive therapies. Despite newer therapies, why do corticosteroids still remain the most impactful drugs in our respiratory medicine?
Good evening, everyone, and good evening to my fellow panelists and all the audience. Corticosteroids are been there since ages, and they are the first to go drug for any pulmonologist or any otherwise. So it's a powerful anti-inflammatory pathways it suppresses the cytokines and inflammatory, and then also the tissue edema. So it's effective in vast respiratory disorders like asthma, COPD, ARDS, like Madam has presented, and even in COVID-19 we've been using it. So it's a wonderful drug. Then also it's a rapid clinical improvement where in exacerbation where we see a dramatic symptomatic physiological improvement, and it's cost effective and also widely available, and hence it's vastly used. So various routes of administration also helps in the administration of the steroids, and many newer biologicals are also used as add-on therapies rather than the supplement. Sometimes even in exacerbations, we might have to use steroids at some given point of time. So I think that would suffice.
Yeah. So as you rightly said, they have a broad spectrum and they can work in multiple diseases that we have been seeing. The cost is a major factor. In resource limited setting like our country, cost becomes an issue and steroids help. And even before the other immunosuppressants act, they act like more like a bridging therapy. Every time you want to give even azathioprine or mycophenolate, you do have to start steroids initially. So yes, they are an important drug in our armamentarium. Next question to Dr. Lovleen. Have we become too dependent on steroids as pulmonologists, or where do you see most commonly overused? I mean, the steroids part. I think, Dr. Lovleen, you are muted. Can you unmute yourself, please?
Am I audible now?
Yeah, we can hear you.
Yeah, thanks for the question, Dr. Mehul. Good evening, everyone. So the point is that yes, we as pulmonologists are overusing steroids, and in many cases they are also misused. If we come to specific diseases, like first, if we talk about our obstructive airway diseases like COPD, the world guidelines strongly recommend that the patients who are having an eosinophil count of more than 300, they are the strongest indication of using steroids. Or patients who are having a count of 100 to 300 with specifically having frequent exacerbations, these are the ones who are going to benefit from inhaled steroids. But still, we are using blanket steroids for patients who are having a non-eosinophilic phenotype or who are not in the category of frequent exacerbation. That's one thing. In COPD exacerbations also, it's recommended, the trials have shown that we should use a short course of steroid, like it should be limited to 30 to 40 mg prednisolone for 5 days. And steroids should also be and acute exacerbation of COPD also, these patients should be endotyped as per the eosinophil count. If the patient is having an eosinophil count of less than 100, these patients should not be given oral steroids. As one trial was done, STAR-2 trial, which was published in Lancet 2024, that specifically had given placebo to the patients instead of steroids, and it was non-inferior to giving the standard treatment with steroids. Coming to asthma, in asthma, we frequently prescribe short bursts of oral steroids to patients, but we don't consider the long-term cumulative exposure dose of these patients. Studies are showing that lifetime exposure of around 1 gram of prednisolone over a lifetime of the patient, that leads to irreversible adverse effects of steroids like HPA axis suppression, adrenal suppression, osteoporosis, diabetes. So whenever we are prescribing the repeated courses of steroid, we should also consider the cumulative dose of steroids. Then ma'am mentioned about the biologicals. Ma'am said when we have exhausted all the biologicals, then only we should come to steroids on maintenance dose in patients who are having severe asthma. But opposite is the case. When we are having a patient who is uncontrolled on inhaled steroids, we are starting the patients on oral steroids, and mostly they are kept on maintenance steroids for indefinite time, and they are not given the benefit of biologicals. One reason might be the high cost of biologicals as compared to steroids. Other than the obstructive airway diseases, if we come to the post-viral cough or acute LRTIs, which are not associated with asthma or COPD, even in those conditions like acute bronchitis, steroids are being used, but that's not a proper indication for that.
Yeah, so if I have to just sum it up for the benefit of the audience, we have become too dependent on steroid because they seem to be a panacea. If you see any patient coughing, whether it is COPD, asthma, whether it is post-viral, we usually tend to be lazy and give them inhaled steroids or oral steroids. And I think there is where we need to keep a check. So Dr. Umar, coming to you, I mean, very specific question to you. Where do you think steroid would be a first-line therapy? In what diseases would you consider versus an adjunctive or a rescue therapy?
Good evening, everyone. First, I would like to thank Dr. Rakesh Sharma, sir, Dr. Amita Vinay for giving us this opportunity. So, steroids are used first line in asthma as inhaled corticosteroids. That is the cornerstone of our treatment, gold standard treatment. Certain identities that require longer duration of treatment, that is more than 2 weeks, such as sarcoidosis, systemic steroids are used. Connective tissue disease associated interstitial lung diseases, hypersensitivity pneumonitis. There are certain allergic manifestations in which first line corticosteroids are used, allergic bronchopulmonary aspergillosis, acute eosinophilic pneumonias, cryptogenic organizing pneumonias, and GPA, EGPA. Adjunctive and rescue therapies are used in severe community-acquired pneumonia, as discussed by ma'am. Acute respiratory distress syndrome, that is ARDS, acute exacerbation of bronchial asthma, acute exacerbation of COPD, upper airway obstruction like post-extubation laryngeal edema, tuberculosis, PCB, in which alveolar arterial gradient is more than 20. These
Yeah.
are the indications of first line as well as rescue therapies for
Yeah.
steroids.
Yeah. Thank you, Dr. Umar. So there was possibly every inflammatory pattern, as Thilagawathy madam said, every inflammatory disorder that you can think of in the pulmonary disorders where you can think of steroids. So now let's focus on individual diseases. Here, the questions are not going to be, straightforward indications and all. I've taken nuances and probably we'll be able to solve all the doubts which are coming up. The questions in the chat box are keep on increasing. So the next question goes to Dr. Sujay. Now we're taking the diseases one by one. In an asthma patient, how should the biomarkers such as eosinophils and FeNO, that is FeNO, influence the steroid decisions?
Okay. I think Thilagawathy ma'am put it correctly. ICS is the cornerstone of treatment for asthma, whether it is as a reliever or a maintenance therapy. So, whether eosinophils and FeNO influence, giving ICS in asthma, then no. But where does FeNO and eosinophils actually help? So FeNO and eosinophils are helping to phenotype asthma, which shows that there's a type 2 inflammation. And it also helps in prognosis, right? So if FeNO and eosinophils are higher, these are the patients who have higher risk for exacerbations and higher symptom burden. But at the same time, these are the patients that will respond best to steroids. So that way, these can help in prognosticate. And apart from that, it can also help in, giving a clue to asthma diagnosis, especially if you don't have anything else, like, your PFT is normal, but the symptoms are like asthma and so on. But one place where FeNO can help is probably where you're giving inhaled corticosteroids. So if you're giving inhaled corticosteroids and the patient is taking it properly, then the FeNO should ideally reduce. So it can, kind of be used to see if the patient is adherent to his treatment, so to say.
Yeah, that's a perfect answer. Like if you're giving an inhaled corticosteroids in the appropriate dose, moderate or high dose, depending on the patient, and the FeNO level don't come down, you need to check whether the adherence is there and whether we need to switch to oral corticosteroids. So yes, and also if FeNO is low, then the Th2 low type of asthma may not respond that well to oral corticosteroids also. So that also helps. So Thilagawathy madam, coming to you, in severe asthma, at what point is maintenance oral corticosteroid therapy truly indicated? Where you want to give oral corticosteroids, and where should you should be avoiding it despite poor disease control?
So actually, in the recent guidelines, if you go by ERS, you go by GINA guidelines and things like that, they have moved away from saying that you should take oral corticosteroids for a longer period of time. First of all, it is not going to be for a long period of time. So maintenance oral corticosteroids are not even there as a routine in step 5 treatment. They are treatment of last resort. We should remember that. So meaning last resort, what all you should tick all the boxes and then only you should come to that box. So what are the boxes we need to tick? So the first thing is get your asthma diagnosis re-diagnosed. There are mimics of asthma diagnosis which you would have missed. So like say, a patient has some vocal cord dysfunction or something like that. So asthma diagnosis needs to be reconfirmed before starting this patient on oral corticosteroids. Then have you checked the adherence, inhaler technique, proper bronchodilator techniques and other things? Have you addressed the comorbidities, meaning, obesity, OSA, or you have GERD, dysfunctional breathing, or you have some nasal polyposis, chronic rhinitis syndrome with nasal polyposis, things like that. All those comorbidities should be addressed properly. Then the next step is, have you achieved the maximum inhaled therapy prescribed in the step 4 and step 5, meaning high dose ICS LABA, appropriate add-on therapy like SMART, MART. Have you crossed all that stages? You cannot have step 1 and then go to oral corticosteroids. It doesn't make sense, right? So you have to go through all this. Then the last but not the least, I think phenotyping is what very important before putting this patient on OCS. So phenotyping meaning this patient can be a candidate of ABPA, can be a candidate of, say, hypereosinophilic syndrome, or can be having some parasitic infection which is driving this disease, or can be having some vasculitis which is missed. So thoroughly phenoendotype the patient at this stage and then decide on oral corticosteroid. So this is not like, if you miss all the steps and then if you're doing it, that means you're inviting more trouble and more complications and side effects than treating the disease. So
Yeah.
that is my take.
Yes, perfectly well said, ma'am. When you're giving an OCS, see where the patient fits. Have you tried everything? And whether the patient is a non-T2 or a TH2 low type asthma, there probably OCS may not be very helpful. Now, shifting gears to COPD, Dr. Dinesh, in COPD, who truly benefits from giving inhaled corticosteroids and who does not? Because there are a few questions in the chat box regarding the same also.
Yeah, COPD, we can say it's a complex disease, and most of the patients who come at a later stage. So here, history of hospitalization for exacerbations of COPD is very important. And more than two or more moderate exacerbations and blood eosinophils of 300 or more do warrant for a steroid adjuvant therapy. And history of concomitant, like COPD asthma overlap, can also strongly favor the use of steroids. What strongly favors is one moderate exacerbation per year, and plus the blood eosinophils 300 or more. And what against is repeated pneumonias, blood eosinophils less than 100, repeated infections, history of MTB or exposure to MTB. These patients we should really avoid. But of course, making them looking at the instead of the OCS, the inhaled therapies. There are so many other inhaled therapies which we give for the COPDs that should be very, very looked into in a much deeper manner.
Yeah, thank you. Thank you. I hope this answers this question. One question is there, when should ICS be withdrawn? So as Dr. Dinesh said, if you have a stable patient, if your eosinophil count is low, you gave it initially, but now patient has been stable, you may be able to withdraw steroids and you don't want to induce infections in such patients. So coming to the next question, Dr. Lovleen, for a stable COPD patient, now this is what we have been talking about. So patient is stable. The blood eosinophil count is somewhere between 100 and 300. What are the other secondary clinical markers which you can use to give or justify an inhaled corticosteroids?
So the eosinophil zone of between 100 to 300 is the gray zone of using steroids. Less than 100, it's not indicated. More than 100, it's strongly indicated by gold guidelines in COPD. So
Yeah.
between this 100 to 300 zone, the exacerbator phenotype of the patient, how many frequent exacerbations he's having, the more than two moderate or one severe exacerbation in the past year, which is requiring hospitalization. That is one of the strongest clinical indicators that this patient is going to benefit from inhaled steroids. Apart from exacerbations, one more point: if we check patients' FeNO levels, fractional FeNO levels, if they are more than 20 to 25 parts per billion, that also shows that patients' airways are inflamed and they are likely to respond to inhaled steroids. And one more factor: if the patient, our patient is an ex-smoker or a current smoker, because in smokers there is a downregulation of histone deacetylase 2 enzyme, which is responsible for anti-inflammatory activity of steroids. So if the patient is not smoking or an ex-smoker, such patients having a eosinophil count of 100 to 300, such patients are going to benefit from ICS.
Yeah, thank you. Very well said. Very well said. So, Dr. Umar, now we move from a stable patient to an exacerbating patient. For an acute COPD exacerbation, what is the optimal dose and duration of steroid, and are we overtreating sometime?
Yes, sir. So optimal dose for systemic steroids for treating COPD exacerbation is unknown. It likely depends on the patient factor. For a non-critical critically ill patient, a dose of steroid is 40 mg prednisolone or equivalent per day for 5 days, as per recommended by GOLD 2026. For critically ill patient, initially high dose of methylprednisolone 60 mg twice daily. Start tapering after 48 to 72 hours, depends on the clinical condition of the patient. Okay.
Yeah.
Yes.
Yeah. So that's perfect answer. I mean, that is what people need to know. In an acute exacerbation setting, there is no perfect dose, but don't go beyond 1 milligram per kg in any patient. 40 milligram roughly of prednisolone equivalent is sufficient. And usually a COPD exacerbation, you are going to check for other factors, for infective parameters, viral or bacterial, and whether the patient has been taking the medicines regularly or not, if there any exposure. So steroids will have a role, but not for more than 5 to 7 days maybe. So sometimes we see a lot of prescriptions over treating, so that is what should be kept in mind. So Dr. Sujay, we were discussing, ma'am spoke about ABPA. So in ABPA patient, we frequently debate the threshold when to initiate systemic steroids. So what do you say? Yeah, and what is the indication based on FEV1 or doubling of IG, central bronchiectasis? When do you want to give steroids in a ABPA patient?
Okay. So first we'll look at when we give steroids in ABPA. There will be two conditions. One is acute ABPA or you're having a relapse of ABPA, right? So for acute ABPA, we'll use the ISHAM criteria. And for relapse also, we use like a combination. So whatever it is not just going to be FEV1 or IgE or bronchiectasis in isolation. We'll have to look at clinico-radiological worsening. And here consolidation, collapse, mucus plugging will play a more important role than bronchiectasis itself. Then we also look at the IgE doubling, and then we look at whether the patient's symptoms have worsened. Okay, so if I look at it just one by one, FEV1, the ISHAM doesn't specifically say FEV1, it says clinical worsening, and they don't give a specific threshold for FEV1 reduction. Doubling of IgE is important, yes, because that is one of the markers to tell us that, okay, the ABPA might have relapsed. And then central bronchiectasis itself is a prognostic marker for ABPA. If it's there, then it's bad prognosis, but just if central bronchiectasis emerges through the treatment of ABPA, maybe not an indication for steroids as such. The importance of including clinico-radiological IgE and other supportive measures becomes important because we should differentiate asthma exacerbation from ABPA relapse, and that is where this nuance would actually come in.
Yeah, very well said. Very well said. So a single doubling of IgE may not be helpful if your patient is clinically stable. So you have to look at the patient in toto. Just don't look at the values and start or step up the medicine that you've been giving. Coming to Thilagawathy madam, to you, in a COPD patient and who's on say let's say on triple therapy without frequent exacerbations, what physiological data points could decode a safe indication to withdraw or maybe to stop it?
So that's a wonderful question, actually, which we face commonly. Okay, we see patients daily coming, coming to us. So should we withdraw the ICS? Patient is on triple therapy, having no exacerbations. Should we withdraw the ICS? Okay, keeping the guidelines apart, I will give a comment on this. Maybe the ICS is keeping the exacerbations under control. We don't know. Okay, once you withdraw, maybe this patient will go and exacerbate. I'm not sure. So that is one point which you should keep in mind, because that is also the practical problem we face. But to remove, so what is it dependent on? So to remove ICS, so to institute ICS, what you did, you looked at blood eosinophil count, frequent exacerbation. If it is more than 300, if patient has frequent exacerbations with eosinophil count between 100 to 300, then you instituted ICS. So if these things are not there, if the eosinophil count is not more than 300, if your patient is not a frequent exacerbator and he is not having asthma COPD overlap component and things like that, then you should safely remove, you can, try stopping taking off the ICS. And the other thing we should consider is if there is an increased incidence of recurrent respiratory tract infections in this group, if they have history of tuberculosis, new onset and things like that, or patient has a non-tuberculous mycobacterial infection and a bronchiectasis phenotype, all those patients, I think ICS, we have to be careful. So other than that, if you look at the eosinophil and the exacerbator alone, that is enough to say that you can remove the ICS. But last one comment is, if at all this patient has a previous history of withdrawing the ICS and exacerbating, then I think that is a clear indication that patient has done the trial for you. So you cannot remove it.
Yeah, so this is experience, guys. I mean, this is what you learn extra from the guidelines, that if you are giving a patient inhaled corticosteroids, your criteria are fulfilled and you are withdrawing it, and then you find suddenly patient saying, "Nee, last time come kiya tha and I got trouble." So this is what you need to keep in mind. Thank you, ma'am. Thank you for the answer. Moving on, Dr. Dinesh, this question is to you, but it's pretty straightforward sounding question. Which ILDs are genuinely steroid responsive and which would be considered steroid resistant, if I may say that?
See, ILD, we can, as Madam has already presented, we can identify them as inflammatory and fibrotic. Most of the inflammatory ILDs can and are responsive, at least in the early before the thing that. So, the steroid responsive are like, cryptogenic organizing pneumonia, eosinophilic pneumonia, hypersensitive pneumonitis, sarcoidosis, CTD, ILD, cellular NSIP. They usually respond. And partially steroid response are the fibrotic NSIP, where we shouldn't even try to give them. Then chronic HP with the fibrosis, then CTILD with significant fibrosis, where we shouldn't be giving. Generally, steroid resistant ILDs are IPF, fibrotic UIPs, advanced end stage fibrotic ILDs, then pneumoconiosis. These places where we shouldn't be even trying the the steroids. So I would broadly classify them as inflammatory and fibrotic. So inflammatory is where we could try, and fibrotic I don't think so. We should be even trying. And I think Madam has already pressed
Yeah.
on the.
Yes, Madam presented a very beautiful slide on this, and this is basically these are the questions we are getting in the chat box. So that's why it is good that we are overlapping with the questions, and people probably are getting the answers that they wanted. Coming to the next question, Dr. Lovleen, have antifibrotics actually reduced the role of corticosteroids in fibrotic ILDs? Like we used to give fibrotic NSIPs and as fibrotic HPs and all, a lot of steroids. Still, people are on sometimes maintenance doses. So, have antifibrotics reduced the role of corticosteroids?
Definitely, the answer is yes. If we talk about the stable patient, not the exacerbated type, the stable patient of IPF. In IPF, the steroids are definitely out as per the Panther trial. In the non-IPF patients who are having a progressive fibrosing phenotype, now these are the patients in whom the inbuilt trial has shown the significant reduction in the fall in FVC. In HP patients or CTD-ILD or RA-ILD patients. So in such patients, when we are starting antifibrotics, we get an opportunity to decrease the dose of steroids to the lowest maintenance dose, and we can also taper off the steroids. So this is one case. Where and another is the exacerbation. If the patient is having exacerbation in non-IPF exacerbations in steroid responsive ILDs, definitely there is role of steroids. But in acute exacerbations of IPF, we are still using steroids, though in low dose, but there is quite weak recommendation with there is chances of harmful effects also with the use of steroids.
Yeah, so thank you for that. So, Dr. Umar, let's just focus on that. I mean, in acute exacerbation of ILD, what Dr. Lovleen was talking about, is the steroid use evidence-based, or it's basically because of standard practice that there is no better option, that's why we use it?
So corticosteroids in ILD primarily utilized as a standard clinical practice. There is not much supported data, high quality evidence or randomized control trials or any guidelines for acute exacerbation of ILD for steroid use. Like Mansur said, there are two distributions of ILDs, fibrotic as well as inflammatory. Inflammatory is quite responsive for ILDs as compared to fibrotic. But in cases of acute exacerbation of ILD, most of us are using steroids to save our patient, because acute exacerbation of ILD leads to extremely high mortality. So we want our patient to save as much as we can do for them.
Yeah, very well said. So, I mean, sometimes it may do more harm, and sometimes it is out of desperation that we give patient is hypoxic sinking in front of us, and you probably might feel, okay, let's try give a steroid trial. So, coming to the different type of ILD, which is progressive pulmonary fibrosis, which is not IPF. Dr. Sujay, how do you decode the indication of steroid therapy versus upfront antifibrotics of a PPF patient, which is non-IPF? And what is there any specific radiological, serological marker which will tip your scale towards a steroid?
Yes. So I think the role of antifibrotics in the recent years is increasing. Like even in systemic sclerosis with the census trial and now with PPF with the inbuilt trial, the role of antifibrotics is quite established. So if you ask me if I have a PPF phenotype, I will always have a background antifibrotic running, which will help preserve some lung function in the future. But now what is important is we need to make sure that, the background ILD itself gets treated, which may be steroids in some cases. Now, what will tip my scales to give steroids in some patients would be some radiological and serological markers, if there is nothing else. So radiologically, if there is GGO or consolidation, I'd be more inclined to give steroids, or certain radiological patterns like NSIP, organizing pneumonia, or LIP, I would be more inclined to give steroids. Or if there are like autoimmune markers positive, like, high titers of MDF5 or, any of the ENA panel that is coming out to be positive, that might also tip the scales. If I feel that, okay, there is ongoing drug-induced ILD, or if there is HP with, antigen exposure that is happening, again, that might be, like triple density sign. Again, these would be just trials of steroids. Like we're saying, the fibrosis already exists. We just want to give a trial, maybe 1 month, 2 months, to see if that helps preserve some lung function or get back some lung function. If it does, then we would have to take a further discussion on what to do regarding immunosuppression. But where I would not give steroids and just stick to antifibrotics is probably, like ma'am already said, maybe it's like a definite UIP that's happening, or if the patient is older and I feel that, the steroids are actually going to lead to a lot of complications in such a patient, I'd keep them only on antifibrotics.
Yeah, so you should target something. Steroid cannot be given as a blind therapy, something will work type thing. You are targeting something. You've seen some inflammation, you have seen some marker positive, only then you're going to add. Now, ma'am, Thilagawathy ma'am, I have a very interesting question for you. We have a asymptomatic pulmonary sarcoidosis, and we know sometimes it resolves. So what precise threshold of functional decline transitions patient from a watchful waiting towards a systemic therapy? Patient has been asymptomatic, you have been following up. When would you want to introduce steroids to these patients?
I think this is a fantastic question. Thank you for that question. I think this is most people's mind go through this when you treat a sarcoidosis patient, and the patient will also be asking you this: when should I start treatment, even though I'm normal? So, as what you have said, I think there is no single FVC value or DLCO value or desaturation. Say if you have this FVC value, this fixed threshold, like you should start. I don't think guidelines recommend anything like that. I think more than what matters more is the trend which matters, or I would say the trajectory which matters. So your previous best to now, is there a declining DLCO? Is there a declining FVC? Is there a new onset of exercise-induced desaturation? So, and then these all matter than a fixed value. So, if you see, the decision should be made on the trend, the symptoms, and the risk of irreversible damage, which is going to happen if we don't treat them. So, sarcoidosis is not like you treat it because it is there. You treat it because you want to prevent the irreversible damage. So, coming to that, then what is meaningful reduction? So suppose you say FVC, the absolute value, you are not dependent. So what is meaningful reduction? So as per guidelines, if you have a FVC which is declining more than 10% from the predicted FVC, then that is a meaningful decline. As far as DLCO is concerned, it is more than 15% of the predicted. So that is also a meaningful decline. And then you have a new onset exercise desaturation, meaning in a 6-minute walk test, if you do an SpO2 and it is less than 88, that means that is a meaningful, evidence for any progression. So this is as far as the physiology or the functional part is concerned. So this is one domain. The other domain is symptoms. The patient has progressive breathlessness. So symptoms, function, and then coming to structure. Structure in the form of CT scan. So you are doing a CT scan and then you see some new GGOs and some progressive fibrosis, then all this matter. So keeping all three together, then only you can take a decision as to whether to treat or not to treat. And we also should remember there are situations where You can have preserved FVC, but your DLCO will be abnormal, meaning these patients will have pulmonary hypertension, which is a problem in sarcoidosis, or there is vascular involvement of sarcoidosis. So we should be mindful of what we are treating, what we are looking at. And as I told you in my slides, in this scenario, if you have an organ which needs treatment, which is involved like cardiac, ocular, and your hypercalcemia and things like that, definitely go ahead and treat. So it is like look at the patient as a whole and then decide.
Yeah, perfect. Thank you, ma'am. Thank you for this answer. So here we move on to the next diffuse lung disease. Dr. Dinesh, this question comes to you. In cases of acute versus chronic eosinophilic pneumonia, how do you decide the duration of steroids? Do you stop abruptly based on symptomatic resolution? Do you taper? Do you do follow-up imaging? How do you decide?
See, acute versus chronic, acute usually respond well and the relapse is usually rare. So we usually look at the symptom score and of course the radiological score as well, but usually the symptom score do favor a lot instead of giving them or subjecting them to the radiological thing like, CTs, X-rays and all that, repeated X-rays. So we should be clinically very vigilant in that aspect. So maybe we can start up to 60 to 125 in acute eosinophilic pneumonia. Maybe we can start up to 60 to 125 depending on the symptoms. Maybe OD. Sometimes we just give the OD, or sometimes we can even give it TID to QID, and maybe until the respiratory failure subsides. And again looking into the ABGs like CO2 and all those parameters, and then subsequently change over to maybe a day or 2 or 3, and subsequently change over to oral steroids. Maybe you can give them up to 2 weeks. If required, extend it, but after 2 weeks, you can abruptly stop it as well. The studies have also shown that. And the relapse is rare in acute. But whereas in chronic, where we have to give them up to from 0.5 mg per kg per day, that is, from 4 to 6 hours at least. For sometimes we can extend it, or we have to extend it up to 2 weeks until the resolution of the symptoms, that is the respiratory failure, and then subsequently reduce it to 0.25. And then maintain it for some time. Sometimes it might even go up to months in case they require. Otherwise, they usually tend to, relapse. So chronic eosinophilic pneumonias usually relapse. But again, as the previous speakers and madam has also specified, we also need to look into the what is the causative agent. If the antigens are not removed, and it's not that all COPDs are only exacerbating because of COPDs. There could be multiple reasons. Including pets, the way they reside, where they're residing, pigeons. There are so many things which can keep things. So we'll have to look into that and also remove the causative agent, and also look and train them and the inhaler techniques and all that stuff, and then subsequently taper the steroids as well, oral steroids.
Yeah, thank you. So if I have to sum it up, in acute eosinophilic pneumonia, you can taper it off over a 2-week period, maybe up to 4 weeks if required. And in a chronic eosinophilic pneumonia, as Dr. Dinesh said, you have to be little meticulous in making it very slow taper off, maybe over 3 to 6 months period, and be ready for relapses. Now, coming on to cryptogenic organizing pneumonia, Dr. Lovleen, this disease is very steroid responsive, but highly prone to relapses. So what protocol do you use to decide how do you taper off the steroids to prevent the recurrence in cryptogenic organizing pneumonia?
Definitely. Cryptogenic organizing pneumonia is very steroid responsive, but many cases, around about 50% of the cases do relapse when we are tapering off the steroids. So there are no randomized controlled trials in literature, and there are no specific guideline recommendations. Only expert consensus protocols are there. The most frequently followed protocols are we start with a high dose of steroid, like 0.5 to 1 mg per kg prednisolone, which we maintain for a period of around 4 to 8 weeks. Then we, after that period of 4 to 8 weeks, like 2 months, we start gradually tapering off the dose, like 0.25 to 0.5 mg per kg per day, or 5 to 10 mg dose reductions every 2 weeks. After that, gradually, if patient is not relapsing, we can reach a lowest effective maintenance dose of 5 mg per day, and that too by the end of treatment of 6 to 12 months, we will very slowly taper it down by 2.5 mg per week. But in most instances, when we are reaching the dose of 15 to 20 mg of prednisolone, the patient will be experiencing relapses. In such cases, the relapses of COP are good in one point, that they are not affecting the long-term outcome of the patient. They are still steroid responsive. So such patients, they don't need the higher induction dose with which we started the induction. We can give them the last high dose of steroid. Like patient exacerbated on 20, we can go back to the 30 mg dose of prednisolone. And one thing more, if the patient is relapsing again and again, we can think of steroid sparing agents also, like MMF or azathioprine, and immunomodulator drugs like clarithromycin or azithromycin. These can also be used in cases of mild relapses.
Yeah. So if I'll tell you, I mean, what I do, I usually start with 0.5 to 1 milligram, depending on the patient, 2 to 4 weeks. That is what I give, and then start tapering. And I have not gone below above 7.5 milligram of with prednisolone equivalent. If there's anybody else giving higher doses, I mean, 7.5 is something which I found was pretty much okay. If the patient is getting relapses, then probably bump it up, as you said, and then again try and taper it down. So this is for cryptogenic organizing pneumonia, and we've had a lot of questions about critical care. So let's move on to critical care. Dr. Umar, the question comes to you. In a severe community-acquired pneumonia, okay, we have a recent evidence, ma'am presented a study. So how do you decode the timing and the candidate selection for giving early hydrocortisone, and when not to use it in simple terms?
For severe CAP using hydrocortisone, already said CAP code 5, which is published in 2023, which includes early hydrocortisone administration within 24 hours with a dose of 200 mg per day for up to first 4 days, and decide accordingly whether we have to continue taper or stop. For giving the hydrocortisone, selection of candidate is very important. That is based on the severity of pneumonia, which is assessed by whether patient is on mechanical ventilation or requiring oxygen support by NRBM or HFNO with a PF ratio of less than 300, or pneumonia severity index is more than 130 points. They included a biochemical marker, that is CRP, C-reactive protein, which indicates which is the marker of inflammation. They included the CRP value of 15 as a threshold. If the value is more than 15, it's suggestive of inflammation, then hydrocortisone should be given. If the value is less than 50 mg per deciliter, the value is not suggesting that much of inflammation. So steroids or hydrocortisone should be avoided or not used.
Great. So, I mean, you should be using it early. It should be a severe cap as per the criteria, and do not use it if you have, viral infections, you have fungal infections, and where it might cause more harm than benefit. So, yes, steroids can be used, but judicious use 200 milligram of hydrocortisone in continuous or divided doses. So, very well said. Next question comes to Dr. Sujay. So we spoke about severe pneumonia. What about ARDS? What is the role of ARDS in steroids in ARDS, if I have to ask you?
Okay, this is one question which is a little difficult to answer. So, should we give steroids in ARDS? Probably yes. So what can steroids do? Lot of studies, meta-analysis have shown that it does reduce mortality, and it can reduce the duration of mechanical ventilation and the length of hospital stay. But what can it increase? It can increase the risk of neuromuscular blockade, neuromuscular weakness, GI bleeds, and probably secondary pneumonias. Okay. Now, what we do know is that we need to select the patient carefully. So it has been shown that giving steroids early, like ma'am said, when the inflammation is still happening, right, within the first week, I think that would be the best time for us to give steroids to the patient. But what we don't know is which steroid to give, Dexa versus methylpred versus hydrocort, not sure. What is the exact dose to give? We're again not sure, because I think up to 2 mg per kg of methylpred dose has been tried. Pulse steroids that go up to 10 to 15 mg per kg has not been tried, probably not very good for ARDS patients because it might increase pneumonia. So stick to lower doses. And again, how long to give this is again something of a debate. As short as 7 days to 1 month has been tried, but I think giving it somewhere about 2 weeks might be a good dose there. Yeah.
Yeah. So, I mean, very well said. Thilagawathy madam presented the DEXA ARDS trial, which said that you can give early. If it's a severe ARDS, moderate to severe ARDS, PaO to FiO2 ratio is less than 200, dexamethasone can be given for up to 5 days, and then probably required, then you can extend it for 5 more days. But if you're giving it in the late phase, that is, a patient is going into fibroproliferative phase, it probably will cause more harm than benefit. Dr. Thilagawathy madam, coming to you, when are steroids indicated in a central airway obstruction, post-procedure airway edema and airway stenosis? Sometimes post-extubation you might get some wheezing or stridor. So where do you place steroids in such patients?
So this is one topic I had no time to discuss in the, when I was presenting, a very important topic. And this is an area where steroids play a major role also, but we should be again mindful as to where we are using. So central airway obstruction, the ultimate, again and again, I'm stressing that same point. Steroids are anti-inflammatory drugs. They are not airway opening drugs. We should remember that. So wherever there is obstruction, don't throw steroids. You will be doing more harm. For example, if you have, certain situations where steroid will help is if you have a significant inflammatory edema, maybe if it is a lymphoma, or if you have some steroid-sensitive tumors, or if you have an SVC syndrome, which is, related edema, and there is some post-radiation induced edema and things like that. So you have a malignancy which is obstructing there. You can temporarily give steroids to reduce the edema and inflammation, but ultimately you have to remove the tumor for you to keep the airway open. So we should be mindful of these situations. Other benign situations, benign conditions which affect the airway, like, vasculitis, GPA, you have sarcoidosis, you have, relapsing polychondritis and things like that. Here, if there is active inflammation, I think steroid helps in these situations. The other places is, I think, as you mentioned, post-procedural airway edema. So the fantastic, that tunnel is a temporary shot, and then you will, it's like, it works like magic, after a rigid bronchoscope, you have, after a dilatation or after a stent placement, short course of steroids are indicated in all those things. If you have a laryngeal edema or something like that, which is very transient, and then steroids do wonders to that. As far as other diseases, if you have if there is fibrosis and fibrotic scar, then steroids are not going to help. You have a tight stenosis, post-intubation stenosis. You can give temporarily steroids, but ultimately you will have to correct it, be it stenting or be it resection and anastomosis. So we should be mindful of all that. The other place where steroids will be helpful is endobronchial tuberculosis. If there is evidence that the airway is going to be stenosed or fibrosed, then you can use steroids like that. So I think it is like, you have to select the patient and then give. Be mindful that steroids are anti-inflammatory. If there is inflammation, it will work magic. If there is no inflammation and you are trying to do, you will be doing more harm than good to them.
Yeah, so this is the common theme coming where you find inflammation, there is where steroids will probably play a role. This is now, Dr. Dinesh, I'm asking you the question which has come 3 or 4 times in the chat box. And in patients with acute respiratory failure from influenza or an RSV, when would you decide giving systemic steroid, knowing that it is going to cause prolonged viral shedding? We usually want to avoid it, but when would you want to give steroids in a severe influenza patient?
Oh, this I'm sure everybody will be facing a dilemma when they're seeing a patient with an RSV. They keep coming back to you and ask, especially nowadays, in the recent past, I'm seeing a lot of patients who come back and say, my cough is not reducing, my symptoms are not going, I'm feeling very, very breathless. Again, here, the steroid responsive phenotypes, we need to know the background, whether they are the asthmatics, COPDs, whether there's the eosinophil count, where if it is COPD also, the high eosinophil count, and the background, and the proven reversible airflow obstruction, and in the eosinophilic airway diseases. These conditions we just need to look into and start the thing. And then again, septic shock. requiring the vasopressors, like Madam had already said, and the organizing pneumonia, where following the viral infections, basically, where you could see there are quite a few as of now, and then steroid responsive ILDs. These are the places where we usually look into giving the steroids, but of course you'll have to be also careful not to give it on a prolonged period. It is easy to give it to a patient, who comes to you and say, no, I'm really having a cough, breathlessness, it's not subsiding, or even at the admission, it's not going down. So you'll have to be really selective, but of course, these are the parameters which we need to look into.
Yeah, perfect, perfect, perfect. Find other reasons to give steroids if you have pure viral ARDS or pure viral infective pathologies, probably steroids will backfire. But if, as Dr. Dinesh mentioned, there are other criterias, these patients would benefit from giving steroids. Coming to Dr. Lovleen, we spoke about ILD exacerbations coming, and patients are using doctors are using high dose pulse methylprednisolone as a default. So, how do you decode an objective threshold for treatment failure by continuing is futile? When you've given methylprednisolone, but where will you find, okay, this is not working and probably I'm going to cause more harm than benefit?
So the rationale of using high-dose methylpred pulses in such patients is to cut off the catastrophic hyperinflammatory response in these patients. When steroids are not working, when we are not getting any clinical response in 3 to 5 days, the indicators being the physiological parameters, like patient is having a low PA to FiO2 ratio, less than 100, fitting the criteria of severe ARDS, that's not improving in 3 to 5 days. Or patient is experiencing refractory hypoxemia, his FiO2 requirement is high, he's requiring NIV or HFNC, but still his saturation is not improving. And a patient who is requiring invasive mechanical ventilation even after 3 to 5 days, he's progressing to that stage where he's requiring there is a decrease in compliance of the lungs, or he's developing hypercapnia. So these are the physiological things. Apart from that, if there is radiological deterioration, we are following up with serial X-rays or CT scans, and there is no improvement, there is further worsening. These are the conditions where the use of steroids is considered futile. Plus the ILD endotype also. Is it IPF or is it non-IPF? In IPF, I will not consider using high-dose methylprednisolone in acute exacerbations. That's my.
Yeah, so if you find a patient who's not responding to methylprednisolone probably in the first 3 to 5 days, probably it won't respond. You need to think about other therapies in such patients. But yes, default is giving methylprednisolone. So there we need to know when to stop. So Dr. Umar, this question comes to you. This is now about in an ICU setting, in a severe but non-ventilated COPD exacerbation or an asthma patient. What clinical parameters would you see as an indication for giving high-dose nebulized steroids as a standalone strategy instead of giving oral or IV burst? Yeah, most of the patients of asthma COPD get an IV steroid, IV hydrocortisone. Where will you use high-dose nebulized steroids in this category of patients?
So, high-dose nebulized corticosteroids are primarily indicated when the patient exhibits clinical parameters that are highly susceptible to systemic steroid toxicity, such as uncontrolled diabetes or diabetic ketoacidosis, in which systemic steroids will lead to hyperglycemia, a severe osteoporosis, in which systemic corticosteroids will lead to bone demineralization, glaucoma, systemic steroids will lead to elevating intraocular pressure, recurrent peptic ulcer diseases, psychiatric instability such as psychosis, acute mania, severe myopathy, fluid retention, uncontrolled hypertension. These are the things.
Yeah. So if you have a patient of, I mean, the first drug of choice probably you would want to give IVs or systemic steroids, but you can try it in some patients. You might want to avoid it in patients who are diabetics or acute psychosis or anything. So their nebulized therapy probably might be helpful. So I have a few special situations for my panelists, and then probably we'll take the audience question. We have a lot of questions. We have covered actually a lot of them. So Dr. Sujay, again, a common question in the chat box coming to you only. What are the appropriate indications of steroids in tuberculosis?
Okay. So the indication for steroids in tuberculosis is not routine. That has to be kept in mind. The treatment is still ATT. And for respiratory complications, at least, it has to be decided on a case-to-case basis. Where there is data is in TB meningitis, TB pericarditis, and in adrenal insufficiency. That is where the indications exist. Now, if we're looking at purely, the respiratory part of tuberculosis, I'll just talk about a couple of scenarios. One is pleural TB. What can steroids do for us? Steroids can lead to earlier resorption of the fluid, can preserve some amount of lung function and prevent the pleural scarring, and can lead to symptomatic relief. But in the long term, it has been shown that none of these actually lead to any clinically significant benefit. So the mainstay is still giving ATT and drainage. So what we can do is probably see if we see that the pleura is thickening, the fluid is not really getting resolved, maybe a short course of steroids can be tried. Second would be endobronchial TB. Endobronchial TB, again, the mainstay is ATT and probably bronchoscopic procedures. Where we would probably use steroids is, again, the data is not very good. Where we would probably use it is where there is an acute collapse, or if the patient is, acutely symptomatic with wheezing and so on, or if we do a bronchoscopy and see that the airway inflammation is more, the airway is more inflamed than fibrotic. Rather than a endobronchial tight stenosis, we find that there is still a little bit of edema, still a little mucosal hyperemia, which is leading to the collapse and symptoms. Then we can probably give a short course of steroids, again, just 1-2 weeks to see if that improves. The data shows that there is probably no improvement in in symptoms, but again, giving a trial would help the patient. Third would be respiratory failure. TB with respiratory failure in, either they're critically ill or miliary tuberculosis. Again, the data is very conflicting. Studies have shown that at least half of the people who land up in such a situation will get steroids. But the data, some people show that there is improvement in respiratory failure. Some people show that there is no improvement in respiratory failure. Again, it would be best to rely on the ARDS guidelines. So if you're having TB with acute respiratory failure, looking like an ARDS picture, inflammatory picture, probably steroids would be a good option. But otherwise, I don't think so. The last one where there is actually, if you are having respiratory issues in TB and where steroids work is when HIV TB with immune reconstitution. So you start HIV patient on ATT, and then they start developing fever and worsening infiltrates and worsening symptoms. There we actually have clinical trials which show that if you give steroids, their symptoms go away much faster. They have shorter hospital stays. So that is one case in the lungs, at least, where you can give steroids, but the others are still on a case-to-case basis.
Yeah, absolutely. Absolutely. So these are the primary indications where you would want to use steroids in a case of tuberculosis or a pulmonary tuberculosis case. Ma'am, coming to Thilagawathy, madam, coming to you, we did speak about this in a little bit, but I'll ask you again. What concrete clinical and radiological boundaries help you decide the indication of steroids in radiation pneumonitis versus post-radiation tumor progression or opportunistic infections or these kind of patients?
Yeah. So this is, I think, you're talking about radiation pneumonitis, right?
Radiation pneumonitis,
So
yes,
radiation pneumonitis is one of the most important steroid role in oncology, thoracic oncology, I think. Okay. So giving steroids to a patient thinking that he has radiation pneumonitis, whereas he has some opportunistic infection or some tumor progression, is definitely detrimental and disastrous. So we need to differentiate all these three. That's your question, right? So the diagnosis of radiation pneumonitis, I think it's very, very crucial that we remember that radiation pneumonitis follows a particular timing. You need to have 4 to 24 weeks after a thoracic radiation, meaning a history which says that there is radiation. That is the first point. And then symptoms which appear within this classical timing, and the symptoms will be vague. There will be no signs of infection. Maybe they'll have some dry cough or progressive dyspnea, mild fatigue, fever or something. There will be no purulent sputum and things like that. Most important is the radiological clue. So most pulmonary diseases, follow the airway, follow the vasculature, or follow the parenchyma. But this is one disease which does not respect anything. It does not respect the fissures. It does not respect the airways. It just follows the physics of radiation. So wherever the radiation beam has gone, the pneumonitis occurs. So that's a classical on the CT. You see a straight line sign, a straight line sign, which is along the exact line where the radiation went. That is an important clue that this is radiation pneumonitis. Whereas, you don't see, changes of, lobar consolidation or respecting the fissure. Nothing like that will be there. So it doesn't respect the lobes or the fissures or anything. So when you have something like that, then you know that there is a history, and then you confirm then that is radiation pneumonitis. So you can have within that, you can have some ground glass opacities or consolidation, but the straight line sign is a must along the beam of radiation. So what is the next thing which can differentiate tumor progression from this? I think we need to do a PET CT scan to decide whether it is really a tumor progression, or if you have some nodular growth or some lymphadenopathy which is new, and then you have another satellite nodule or something like that, then that points towards tumor progression. The other thing is opportunistic infection. I think that has its own caveat. We need to do a bronchoscopy, do a BAL sample, and then decide whether this patient is definitely having some opportunistic infection, where infective symptoms will be there, purulent sputum, fever, and then you will have elevated inflammatory markers like CRP, procalcitonin, neutrophilic leukocytosis, things like that will be definitely there for us to clear. So, and then you can have some new tuberculosis, cavitation, treen, but all the other infective components of a CT imaging will be there, where bronchoscopy will help you to, finalize what is there. So if you have a situation with fever, infiltrates and neutropenia and things like that, then I think you should go with infection. If you have some mass and satellite nodules and things like that, you go with tumor progression. And then if you have a straight line sign, nothing else except along the radiation, and typically radiation pneumonitis with a clear indication that there was radiation before, then I think that helps you to say this is only radiation pneumonitis. And we should always remember radiation pneumonitis is a diagnosis of exclusion. You need to rule out all the infections, rule out everything, and then finally only you can arrive at the diagnosis.
Yeah, so it is only in these patients where you might want to use steroids. As ma'am rightfully put, you have to take a painfully long history and investigation chart before you want to give steroids in radiation pneumonitis. Dr. Dinesh, coming to you, we spoke about a lot of things about when to use steroid. How will you modify it if you have a patient of diabetes, an obese patient who doesn't want to gain weight, osteoporosis, a patient with recurrent UTIs, for example? How would you modify your therapy of steroid in such patients?
It's simple. I mean, shortest effective course, if at all it is really warranted. Otherwise, we have a lot of other modalities like, ICS, LABAs and all that. We'll have to introduce that and of course teach them personally. And if at all you're using it, for example, in diabetes, it should be a shortest effective course. And tapering when evidence supports an abrupt cessation, especially in COPD patients, if at all it's required. Then aggressive glucose monitoring and steroid sparing alternatives like, the biologics, if at all they are affordable. The major question arises if at all they are affordable or non-affordable. So that becomes a problem, because if in diabetes also they'll be using a lot of other medications where they are definitely costly. Irrespective of from where they are getting, they're still costly, because most of the households who usually develop this exacerbations or the ILDs, or they're all the lower socioeconomic status where they might not be even be able to afford it, and of course the aging population, which we are already, it's a concern there. And then anticipate insulin escalation rather than reacting to it, and to the hyperglycemia. In obesity again, we have to the same rule holds good here. Avoid prolonged use. And in osteoporosis, of course, short course, then vitamin D, calcium supplements with regular inspections, investigations, and steroid sparing agencies play a huge role, provided they are affordable. Not all patients are, but of course, you can still use the steroids, but be cautious and before you use it. Yeah.
Yeah. So I mean, one place, one question also has popped up. I'm just adding to that question. Whether you use methylprednisolone, prednisolone, deflazacort in such patients. I mean, do you have a preference in diabetic patients? Can you prefer, like, it just depends on the patient to patient?
See, all the steroids do definitely raise your glucose levels. I would definitely not prefer deflazacort in such in all the patients. Of course, methylprednisolone in the shortest course, I would definitely prefer the methylprednisolone.
Perfect. Yeah. Same.
So deflazacort I usually avoid because it's definitely going to raise your sugars, but it might not be as effective as your methylprednisolone, which I have definitely seen.
Yeah, so it's a good diabetic patient. Good sugar control is important if you use deflazacort or you use methylprednisolone. And even as Dr. Dinesh said, even personally, I prefer giving methylprednisolone more than deflazacort, because if the effect is less, the side effects are going to be less. I think that is how deflazacort works. So monitor your sugars, and other things. Probably see whether you want to continue or not. Recurrent infections, osteoporosis, you might want to see whether the indication still exists, and if it exists, you have to manage the side effects that come along with it. Dr. Lovleen, this is a very common question, a very simple question on the face of it. A patient has on an inhaler. So how do you decide switching from a dry powder inhaler to a meter dose inhaler containing steroids if you want to prevent oral thrush or dysphonia?
So the patient selection or the device selection is very important in our patients of COPD and asthma. A DPI is a very portable device. There is no hand-breath coordination is required, but it has some problems. It requires a certain amount of inspiratory flow, certain inspiratory effort from the patient, around 30 to 60, which may be difficult for very elderly patients or young patients. And that inspiratory flow is required to break up the drug particles from the carrier particles so that the drug can be released and inhaled. And when the inhaler drug strikes the back of the throat, it can lead to these side effects. If we are giving a DPI to a patient who is having low inspiratory flows, then the drug particles, the big drug particles, they can clump and they can just deposit on the back of the throat, and they can cause the problems of oral thrush or hoarseness or dysphonia. So switching to such patients, it's better to switch to a pressurized MDI with spacer. Spacer removes the need for a certain inspiratory flow, and it also decreases the velocity of the spray which is coming out of the device. So there is less impact on the back of the throat and more lung deposition is achieved. But the MDIs, they also have some problem, like the spacers are bulky devices. They are not very portable. Soft mist inhalers is another option which can be used, but soft mist inhalers, they have limited amount of medications which are available in soft mist inhaler forms. So that's one thing. So that's what I wanted to.
Yeah. So if a patient is getting oral candidiasis due to your dry powder inhalers, consider shifting them to PMDIs with spacer. And obviously, it goes without saying, we have to make sure they are taking the inhalers properly, the technique
Correct
and
technique.
the
Yeah.
correct technique, and gargling the mouth and all those things come together. Last two questions, and then we go for the rapid fire audience question. Dr. Umar, this question is to you. A straightforward question and probably the most important question. If you could create a practical steroid checklist for pulmonologist, what would you put in it? And if you could tell me three important questions to ask before prescribing steroids. Dr. Umar, you are on mute. You are on mute. Can you please unmute yourself?
So before prescribing steroids, the pulmonologist should ask himself a few questions before prescribing. First is the target pathology is to be steroid responsive or resistant or harmful. If the pathology is steroid responsive, go for it. If the pathology is steroid resistant or harmful, don't go for it. Second is the status of the uncontrolled or unrecognized comorbidities, like we discussed earlier: diabetes, peptic ulcer disease, psychiatric illness, latent tuberculosis, cataract, osteoporosis. Rule out these things also. The third and most important thing is the anticipated duration of treatment, whether we want to give the steroid for a shorter duration for 3 to 7 days or longer duration for more than 40 days. Patients should know the possible adverse effect of the steroids as well as alternate treatment available for the disease that steroids has to be prescribed.
Yeah, yeah, very well said, very well said. So I would give steroids and I would compare it to investing into the stock market. Know your target, know if you have any other alternatives available, and what is your exit strategy. When are you going to taper off the steroids? And these are the three important questions I need to answer to the patient. And obviously the comorbidities and how long, the cost and everything come into the picture. So the next question and probably the last one which I had made, Dr. Sujay, what are the most common steroid-related complications do you encounter in your practice, and how do you prevent them and probably manage them?
Okay. I think Dr. Dinesh and Umar have already
Hmm.
addressed this quite well. I'll just sum that up. So first of all, inhaled corticosteroids, right? Inhaled corticosteroids would be most commonly dysphonia and sometimes oral candidiasis. The best way to tackle this would be to prevent it. Check your inhaler technique every time. Make sure that they're using a spacer if they're using an inhaler, and mouth gargling and rinses every time they use their inhaler. Now, if the fungal infection has happened already, probably a short course of antifungal like fluconazole might help. Then if you come to systemic steroids, much scarier, especially in the setting of ILD, because that's where we're probably using steroids for a much longer period of time. And that's when you're going to start noticing hypertension, and then sugars going up and down, and then osteopenia and osteoporosis. Most commonly, if you look at the metabolic side effects. Now, how I would deal with this proactively is, if they're already diabetic or something like that, I would get in touch with their endocrinologist or their physician, tell them that, okay, we're going to hike up the steroids now. What do you want to do? Do you want to check the blood pressure more frequently? Do you want to check the sugars more frequently? Or do you want to up the insulin up front? If they're already admitted, then we go ahead with a direct sliding scale rather than oral hypoglycemics, and then tackle the sugar acutely, and at discharge we kind of fix the insulin and taper that down as well as we taper off the steroids. If they're older and if the steroid duration is much longer for more than 1 2 months, then we look at also bone mineral density actually coming down, where we actively prevent it by adding calcium and vitamin D upfront. And if they're older and if they have other comorbidities, probably get a DEXA scan as well. The last thing and most important would be infections, either secondary bacterial pneumonias or even opportunistic infections. How I like to deal with this is, especially if an ILD and I know that I'm going to give steroids for more than 4 weeks, then I upfront start the patient on Septran prophylaxis to prevent PCP, and ask them to come in early if they have a fever or something like that. Apart from that, the most important things I think everyone else has stressed upon is, one is see if at every visit, if the patient continues to have an indication for steroid, and whether they still need that steroid, and make sure that at each visit you kind of tell them that this is why we're continuing the steroid and this is the duration we're actually going to look at. So even if the patient doesn't come back to you, he has a plan that okay, by this time the steroid should have been stopped, or should I continue, and things like that.
Yeah, very well put. So, I mean, this is probably the end of the questions that I had in mind, and we have still 1987 people listening, and I think more than 200 questions, but I think we have covered most of them. So, I will try and see if something which we haven't covered, and probably anybody can pick them up, or probably I'll answer them if it's a show. So, first question by Dr. Raghu: how long steroids to be continued in steroid responsive ILD and IPF? I think probably if a steroid responsive ILD, cellular NSIP or ILD, I think we do continue it. Probably there is no endpoint unless it converts into a fibrotic ILD, where you probably need to add antifibrotics and taper off your steroids. I think, is there anybody else wants to add anything to this? And yeah, so Dr. Dheeraj, we spoke about role of steroid in pulmonary tuberculosis, pneumonia indications, we spoke steroid. Okay, what is the maximum Dr. Sanjeev was asked, what is the maximum duration for steroid which is safe to use? Anybody wants to take?
I would say there is it's never a safe domain to be in. So steroids have their own advantages and disadvantages. We just have to weigh the pros and cons and use them judicially. And nowadays we do find also many patients, they keep taking it across the counter. And that is a very thing. So, and they don't even tell you that. So that again is a problem. So only when you get your cortisol levels done, or when they come up with if at all they have diabetes, or if they not have diabetes, or with the oral thrush or urinary tract infections and recurrent other infections, and if somebody else has picked it up and then they come to you, what to do? So the prolonged use is definitely not a indication. We have a lot of other modalities, including the inhaled corticosteroids. Even there, we have to be judicious and also be, watchful and taper the dosage as and when required. And if required, give a long dosage. Of course, biologicals, if at all they are affordable. If not, the lifestyle modifications. I do take a lot of time in explaining the patients what to do next, how to modify, and of course the detailed history is very important. The job profile, the stay, where they have the travel history. For example, a pure RSV, we don't have to give the steroids. Of course, so these are the things, indications. So we'll have to be very careful when we are thinking of giving the steroids. So I don't think it should be a prolonged usage. I have many patients. In fact, today I had 4 or 5 patients who've been using steroids for more than 3 years. Somebody had started it and they've just prolonged it because they're feeling good, and now they come back with the symptoms blown up, the other symptoms blown up. So that's a challenge. So I feel you should be really respectful to your body rather than, yeah.
So I mean, to be very specific, maximum duration that I have used probably in a patient till the end of life could not tolerate azathioprine, mycophenolate, had liver dysfunction, could not give any antifibrotic to the patient. So there is going to be that one-off patient where you might have to continue for a long time and be watchful for side effect. That's all we can say. Then role of steroids with severe. Ma'am, you are muted, ma'am. If you want to add.
So I want to make a point here.
Yeah,
If you're going to give steroids for a duration beyond some time, then you are going to look at steroid sparing agents. You're not going to just, if it is asthma, you're going to look at biologics. If it is, if it is your vasculitis or things like that, you're going to institute rituximab or something like that, where you're going to reduce the steroid. But if you start steroid and then if it crosses more than 14 days is what the guidelines say. If you have a low dose within, say, less than 20 milligram for less than 15 days, it doesn't matter. If you go beyond 14 days and if it goes beyond 4 to 6 weeks, then you need to add, you should be very cautious of your osteoporosis, adding calcium, vitamin D, and then looking out for infections and things like that. So if that patient needs steroids, you cannot deny steroids. We are not bothered about the duration. A vasculitis patient who is suffering, who has some, in the airway, there is obstruction, there is nodules due to GPA and things like that. You cannot deny steroids to that patient and the disease is active. So you should be mindful of all this and always look for steroid sparing agents in that particular disease, be it biologics or your immunosuppressions and other things, and then keep it at the minimal dose where the disease is under control.
Yeah, thank you, ma'am, for that. Dr. Mehek has asked, when do we consider tapering steroids? I think we have answered for every disease. Dr. Atif Patel wants to know what is the genomic versus non-genomic effects of corticosteroids in airway inflammation. If anybody wants to pick that up. Okay, so the genomic effects.
Basically the same effect.
Yeah,
basically the same effect, it's not so if you classify it as genomic, non-genomic, you're talking about the epithelial level and the genetic level, the DNA level. So it's one and the same. We are talking about all the side effects and things like that. So it is the same actually, nothing different. So what are the effects when the steroid is given at the nuclear level, and what are the steroid effect which is at the airway level, the mucosal level? That's the difference it makes.
Yeah, so the non-genomic level will be the one which starts the effect early, and the genomic level takes a little time to act because
Yeah.
it has to work via the DNA. So probably that is what it is. Dr. Satya Ranjan wants to know methylprednisolone versus deflazacort. I think we covered it. Probably all of us do prefer methylprednisolone.
So I will make a point here. Between
Yeah.
the three steroids, we need to be very clear about hydrocortisone, about methylprednisolone, and dexamethasone. Okay. So if you keep these three, hydrocortisone is in one spectrum and dexamethasone is in the other spectrum. We should be mindful of how they act, what activity they are having. So if you take hydrocortisone, it has got 50-50 of glucocorticoid and mineralocorticoid. If you take fludrocortisone, it is 100% mineralocorticoid. But if you take glucocorticoid, it is in between. It has, it has a very potent anti-inflammatory action, 5 times more than hydrocortisone. But dexamethasone has 25 times higher than your hydrocortisone. So if you are looking at a disease where inflammation is the main problem and you need a potent anti-inflammatory, then go for methylprednisolone. So this surviving sepsis campaign, remember, they are talking about severe sepsis where there is vasopressors and things like that. So you need hydrocortisone. But as pulmonologist, I don't use so much of hydrocortisone. I look at methylprednisolone at a different angle because, I need a potent anti-inflammatory, somebody who's desaturating. Their interstitial edema is there. You need to get the oxygen through that system. Then you need a good potent anti-inflammatory. I'm not worried about the mineralocorticoid effect of the steroids. So like that, you should have a different opinion on what. If I institute dexamethasone on a patient, then dexamethasone is a potent anti-inflammatory, has prolonged action. And then if the patient has sepsis, I will not, even if I withdraw, then the effect of the steroid will continue, immunosuppression will continue. So dexamethasone is primarily for the brain where there is no mineralocorticoid activity. And then suppose a patient is edematous and then you want to give a steroid. I think methylprednisolone is better. If the brain edema is there, then dexamethasone is better. Hydrocortisone is not going to have that effect on that. So that is for severe sepsis. This is for typical ARDS patient where you're struggling with severe ARDS and the PaFiO2 ratio is very high and things like that. So each one has their place and nobody is wrong in instituting all three. There is a frequent, difference of opinion between the intensive care people, pulmonologists and others. But all of them are right, believe me. But in the right patient, in the right dose, and the right type of steroid is what we should do.
Yeah, very well said, ma'am. And this was probably a master class in when to use what steroid. That was very good. And as far as deflazacort is concerned, probably methylprednisolone should be preferred. In diabetes patient, you might want to cut down if the sugars are going haywire. Dr. Atif also wants to know non-COVID ARDS. I think we spoke about it. Any ARDS which is viral, probably you want to avoid the high dose steroids. If it is any other reason for ARDS, there is evidence we can use for the first 3 days in the initial inflammatory phase. Okay, this is the yeah, Dr. Lovleen, you want to add?
I wanted to stress one point. Whenever for any indication our patient is on for any disease, we are putting him on maintenance steroids, long-term steroids. We should not forget about giving PJP prophylaxis. That's very important.
Yeah. So giving prophylaxis to prevent pneumocystis infection is very important if you're giving any immunosuppressant for a very long time in the therapeutic doses. So this is an interesting question. Dr. Atif wants to ask betamethasone, for fetal lungs versus maternal asthma control in pregnancy. Will it work? So maybe probably what you're trying to say is if I give betamethasone for fetal lungs, will it help for maternal asthma? Maybe not. You give betamethasone for the fetal lungs, and for maternal asthma control, you have to give the standard management that you are going to do. Betamethasone will probably not help the maternal asthma that you think. And for fetal lung development, we usually give 2 doses in premature or labor, if for that matter you're giving. Anybody wants to add anything to this? Yeah, take it. Okay, in acute severe asthma, when should IV steroids be preferred over oral steroids? Anyone?
So during a severe exacerbation
Yeah.
in the ICU, probably.
Yeah.
So as per guidelines, if you say oral prednisolone is equal to IV, need not give IV prednisolone to all patients, even if you have a severe asthma. But if the patient is needing ICU care, mechanical ventilation, and things like that, it makes sense that we give an IV steroid.
Yeah, yeah, very good. Oral corticosteroids, chronic in COPD, very harmful unless necessary. Any other indication exists? I would
Only
not.
during exacerbations.
Yeah, ma'am,
Short
chronic.
course.
Chronic, not
No,
justified,
no
not
indication.
justified, not justified. We already spoke about the tuberculosis part. How do we decide? How do we decide
See,
between? Yeah, ma'am.
in miliary TB, when to give steroid? That's one question, right?
Yeah, ma'am. So that is
No.
basically if the miliary TB, Dr. Sujay answered it. If miliary TB is fitting into an ARDS pattern, probably then there is tubercular meningitis, and then there's the two places where in miliary TB you would want to give. You cannot be like any miliary TB. You're not going to give systemic steroids to all patients. Okay, we've done this. Okay. How do you decide between steroids alone versus combination immunosuppressions in ILD?
That's an interesting question.
Yeah.
Yeah, so see, that's basically a very awesome question. Okay, whoever asked that. So when do you decide, do you give steroids and when do you give combination immunosuppression? So the first time you're seeing the patient is really sick in the ICU, acute, steroids, it works within hours. So remember, all your immunosuppression takes some days to work. Yeah, it might take hours, days. If you take rituximab and all, it takes 1 to 2 days. If you take cyclophosphamide, 2 to 3 days. So much, and weeks also sometimes. So steroid is one where it will act immediately. So I think steroids are used when you need an acute setting, you need immediate immunosuppression and things like that, and then slowly follow it up with a combination immunosuppression and reduce the dose of steroids. So it's not one over the other. It is starting with steroid. That is like induction phase or something like that. So you start with steroids, add some steroid sparing agents as you progress, and then reduce the dose of steroids.
Yeah, yeah, yeah. So, very well said, ma'am. How does smoking affect steroid responsiveness? I think Dr. Lovleen did mention about it. And how can blood eosinophils guide steroid therapy? There are criteria, more than 300 in COPD patients. Why are steroids not recommended in IPF? There was probably a Panther trial which showed that there will be more damage. It's on fibrotic, primarily disease, and steroids are anti-inflammatory, so there is no theoretical rule also in such patients. This is good. When should adrenal suppression be suspected and evaluated? A patient who has been on prolonged steroid, when would you suspect and how? Yeah, Dr. Lovely, you want to answer that?
So if we have been giving repeated short courses of oral steroids to our patients of asthma, we should be cautious. I mentioned the cumulative dose of steroids is very important. The lifetime exposure of 1 gram of prednisolone we should keep in mind. So if we have been using repeated courses of steroids, we should consider adrenal suppression. We should check for morning 8 a.m. cortisol levels if we are going towards that HPA excess suppression.
Yeah,
That's
so
my
we if you're giving a prolonged systemic steroid course or repeated systemic steroid courses, that is where you need to keep a watch on your steroid levels in the body, and probably you may need to involve an endocrinologist if you do find there is suspected adrenal suppression, and you do need to continue steroids in such cases.
Yeah.
Okay.
So just one thing. So like
Yeah.
basically, I mean, yeah, in these patients, they'll be like chronically, usually when you give like steroids for lung conditions, the first thing that improves the patient feels better. But here, if the patient is always continuously tired, the BP is, low, instead of the sugars going high, the patient is having hypoglycemia or electrolyte imbalances, recurrent vomiting, that is probably when you might want to think about this. And like you said, involve the endocrinologist and get that tested. So.
Yeah, yeah. So don't be scared of calling in for help. Yeah. How should treatment response be? How should treatment response be assessed in pulmonary sarcoidosis?
So pulmonary sarcoidosis, as I told you, in any pulmonary disease, we should remember there are 3 domains. One is the clinical domain, the next is the physiological domain, and the last one is the imaging or the structural domain. So as far as clinical domain is concerned, symptoms. So if your symptoms have subsided and things like that, and then physiological domain is in the form of lung function test. So either it be PFT, DLCO, and then imaging, you see resolution in images. I think we should take everything together and then decide whether this response is good or not.
Yeah, yeah. So there was some discussion in one of the WhatsApp groups about PET scan and all. So any imaging, as ma'am said, imaging can be organ specific. You need to see the organs where you can use a PET, you can use a CT, or maybe you can use some other radiological modality. I think we are running short of time. I think there are too many questions still pending, and I'm sure we've answered most of them. Um, how would you manage steroid-induced hyperglycemia in a respiratory patient? I think as Dr. Sujay has already mentioned. Sujay, you want to add to that?
Yeah, no, it's all about just being proactive. When you start the steroids, you just know that the sugar is going to go up. If they're inpatient, you do routine monitoring pre-meals, post-meals, and then you start them on a sliding scale initially and then fix the insulin. If it's on an outpatient basis, they already have an endocrinologist, just ask them to titrate it for you. Or you can get a sugar readings yourself, daily fasting or daily postprandial, and then see where the sugar is at. And then you might want to change, either add an insulin or change the OHA itself.
Yeah. So sometimes when you find that the response is erratic, switching to insulin is always better than going to OHS. And then probably once the sugars are stabilized, then probably switch over to the oral hypoglycemics. I think I will take last two questions. I think they are good questions. How would you approach a suspected steroid-resistant asthma? Anybody wants to take?
I think steroid resistant asthma, I think maybe it is pseudo resistant.
Pseudo-resistant.
So you have to
Yeah.
go through the steps as we discussed, like whether it is really asthma, whether it is asthma mimics and things like that. And why is it maybe a overlap with COPD or something like that, or is the disease progressing towards COPD? We should, I think, we should do a thorough workup on this patient, and before deciding that this patient is steroid resistant. I think in this place, biologics will be of great help if you phenotype the patient.
Yeah, and there is also this, like if it's a TH2 low, probably
Low
what the
asthma.
person who's pointing towards is a TH2 low asthma. In such cases, theophylline work very well. I mean, there is a very big fear of theophylline, but I think all the people here on the panel will agree theophylline in Indian patients do work very well. You do have to monitor for side effects.
Yeah, that it works well because there was a question on HDAC2. Okay. So
Ah,
this T2 low phenotypes, they have neutrophil predominant sometimes. So
exactly.
they have that HDAC2, which is, which helps because that is where the theophylline works. HDAC2 is activated and it helps. So maybe theophylline is having an indirect effect on that. That's why it works.
Yeah. So, okay, last two questions. Role of steroids in MCTD where lung is already fibrosed, but there is subtle inflammation.
So I told you that, there are some clues. If you
Hmm.
have ground glass opacity consolidation away from traction bronchiectasis and honeycombing, then that is an inflammation which will help you to say that that will definitely be steroid sensitive. And then if you have CRP or your inflammatory parameters, ferritin and things like that, which are very high, you can use them. And clinical parameters also, worsening, new onset ground glass opacities, all those things will help you in any fibrotic lung. This is the clue. And the last one, lymphocytosis in BAL. BAL
Yeah.
lymphocytosis, very important, more than 30%. Definitely your steroid is going to work.
Yeah. Very well put, ma'am. And use of steroid in severe PJP in an immunosuppressed patient with respiratory failure. I think there is use
So
of
there is
steroid.
a clear indication in
Clear
guidelines
indication.
as far as HIV and severe PJP is concerned. There you have to use a steroid. If it is a non-HIV patient, then only in respiratory failure you should take a individualized call phenotype and then give steroids.
Yeah, so basically there your focus is reducing the inflammation. As ma'am has been stressing, it is an anti-inflammatory agent. Use it for inflammation. If you have a severe PJP patient with a respiratory failure in a non-HIV candidate, you have to think, I'm giving this for reducing the inflammation, and that should be the duration, that's it. And the last question, probably DPI or MDI, which is best? I think the patient decides. You don't decide that. I mean, there are going to be a lot of criteria. Patients prefer portability. Patients require inhaler. They don't like the powder. They don't like the cold freon effect. Too many things. So let the patient decide. You should be aware how to use. and explain it to the patient. So I think I think we have crossed our time allotted, and this has been a fantastic session and learning experience for at least me. I'm sure it has been for all the panelists. I would like to thank first the ICS committee, the Dr. Rakesh Chawla sir, Dr. Amita Nene ma'am, and our excellent speaker, Dr. Thilagawathy madam, Dr. Dinesh and Dr. Lovleen, Dr. Umar and Dr. Sujay for the excellent panel discussion. One last, you can have a parting comment from all of you, starting with you, ma'am. Thilagawathy madam.
Yeah, I think steroids are game changers in pulmonology, and we use it very common. Use it for the right patient, at the right dose, for the right duration, and always have a look at the steroid sparing agents wherever needed in situations.
Yeah, Dr. Dinesh.
Ma'am, rightly put, be cautious, sparingly used, and look at the alternatives. There's no question about it.
Yeah, Dr. Lovleen.
Just take care of the cumulative oral steroid dose when we are giving repeated burst of oral steroids.
Yes, yes, Dr. Umar.
I agree with ma'am. Right dose, right duration.
Dr. Sujay.
Every time you see your patient, just ask, does this patient still need steroids or can I stop it?
Exactly, exactly. So even though you might want to continue the disease, you have any other agent or anything which can be added. So thank you all. This is all from my side. We've taken most of the questions. I hope you've answered all your questions in the talk, in the panel discussion, and from the audience question poll. Thank you and take care. Good night. We'll see you in the next session.
Thank you. Good night.
Thank you.
Thank you,
Thank you.
everyone.
Thank you.
everyone.
Thank you.